Good morning, everyone. Thank you very much, Francesco. Thank you to Gerbe for organizing this symposium about focused on glue. My disclosure. So I will go quite fast. I mean, you all know. I mean, it's an easy disease, varicocele, and maybe there is a mean to a room to improve a little bit the outcomes by choosing the right embolic agent, and I will try to convince you that glue can be a good option. So you know that it's very frequent. A lot of patients, you will see a lot of patients for varicoceles between 20 and 40 years old. It's mainly on the left side. It can be bilateral, and this is a dilation of the pompiniform plexus by incontinence, primary incontinence of the left spermatic vein. In most of cases, there is a clinical classification, and the indications for treatment in general, whatever the technique, surgery or embolization, are symptomatic, meaning pain in most of cases. It can be couple infertility and especially alteration of semen parameters. We have a big center for infertility, and this is probably the main recruitment. And it can be both. It can be combined, and this is the main indications. If we look at the literature comparing the different techniques, surgery, you have a lot of surgical techniques, but probably the most competitive compared to embolization is subinguinal microsurgery. But for some reason, most of urologists are not doing this technique. But still, if we compare, embolization has many advantages over microsurgery, local anesthesia, ambulatory patient, no job arrest, no risk of mortality, no risk of testicular atrophy, no risk of hydrocele, no scrotal hematoma, and a rate of recurrence which is very low depending on the embolic agent you use. Significant clinical improvement if we include all techniques, surgery and embolization. So because some people are still thinking that there's no need to embolize varicocele, or maybe we can discuss about PCS, but for varicocele there is no more discussion. This is efficient on pain, on spermogram, on pregnancy rates. We have a lot of papers, meta-analysis, even in case of failure of ICSI, in case of azoospermia. So whatever the technique, with some techniques giving some better results. So if we go a little bit deeper with the use of embolization, everything works. There is no randomized study comparing the different embolic agents. So everything works. But maybe a glue and lipid can work a little bit better. There is only one paper, if I can, only one systematic review coming from UK comparing with a lot of bias. It's retrospective. This is a meta-analysis, a systematic review. We have a lot of papers comparing COIS alone, COIS plus sclerosing agents, sclerosants alone and glue alone, with few papers. And it's a shame with the use of glue compared to the other embolic agents. And what they report is that the technical success is very high, regardless of the embolic agent you use, more than 90%. Very surprisingly, the addition of sclerosing agents in that paper in the embolization with COIS are not adding on the effectiveness, but it's more likely to increase the cost and duration. And there is only one, if we focus on glue, one randomized study comparing two glues, NBCA, which is hisacryl, and metacloxysulfonane NBCA, which is Glubron 2, with no difference in terms of clinical outcomes, no complications reported. But just to let you know that discomfort, what we can call discomfort, probably because of delayed inflammatory reaction that we have with glue, a little bit more than with any other embolic agents, is a common side effect, which is not a complication, but which is something which is part of the intervention. So this paper that we have published about the use of glue and lipidol for improving semen parameters, it has impact on all parameters, the motility, the vitality, the morphology. So it works with glue as with other embolic agents. But maybe the main advantages of using glue and lipidol are that, I mean, as usual with glue, it's very fast. It takes few seconds to embolize. I will show you an example here of typical phlebography, retrograde phlebography under Valsalva that we do. And probably the main, it's probably a matter of embolic agent, but a matter of technique as well. For some reason, there is a dogma that we have to embolize with COIS from the inferior sacroiliac joint to the almost the renal vein. We do exactly the opposite. because every time you get recurrence, this is coming from some branches coming from the saphenous vein, so very low, below the iliopectinate bone level. So that's why I like having some glue below. So you can see the microcatheter in front of the obturator wall here, and then we start to use glue and lipidol in a 1-to-1 ratio to get fast polymerization, to make sure that in case of reflux, it will be quickly polymerized before getting any kind of migration. So it's an easy embolization, but you need to think about injection while removing the microcatheter, while asking the patient, if needed, for Valsalva to fill in all branches properly. And we glue up to the iliac crest level. No need to go higher than that and to take any risk for nothing. To me, the tricky part and the most important part is to embolize the distal, not the pompiniform plexus, but just above to avoid any kind of recurrence. So we have used everything in varicocele in the past, coils, plugs, sclerosing agents, combination glue, and we have shown in a retrospective way that glue, which is obvious, gives lower radiation exposure because it's faster, for the simple reason that this is faster. So very obvious. And in the systematic review coming from UK, at 1 year, glue appears to be the most effective in preventing recurrence. A recurrence which is 2 to 3% with glue in this paper versus up to 15%, on average 12%, which is quite high to me, but 12% with coils, more or less with sclerosants. So when we talk about cost, we have to talk about everything and not only the additional cost of using a microcatheter during the intervention, but the rate of recurrence on the long term, because if the patient has to come back, this is an additional cost as well. So it's quite cost effective in the end if you take into account everything, the time, the rate of recurrence, you know that this is money as well. But all I just said is true if you use it properly. To me, you have, in my personal experience, to use the right dilution. This is a 1-to-1 ratio that we use. In most of cases, I would say 1 ml of glue and 1 ml of lipidol is enough to occlude a standard spermatic vein. If it's really, really very big, you can use 2 and 2, but in most of cases, 1 and 1 is enough. So we do the dilution. We inject with a 5 ml syringe. Luer lock to make sure that it's well connected to the microcatheter, and we start by injecting 1 ml of dextrose because you don't want to flush the pompiniform plexus in that case, just the dead space of the microcatheter, and you start by injecting. You see the behavior of the first drops, and then you start to remove the micro. You leave the tip of the 5 French above the iliac crest, and by removing the micro, you can get, you see here, with Valsalva occlusion of all branches in a very fast way, and you can have a feeling of all branches. So you see a typical embolization, quite fast, quite low, but again above the pompiniform plexus. I like, again, having some glue below the iliopectinate bone level, because even if you have multiple channels, you always have some connection at that point. So if you embolize below that point, even if you don't feeling all branches, for sure you will avoid any kind of recurrence. But anyway, you will be able to fill in all branches in most of cases. It can be used even if it's very exceptional. The technical failure by endovascular approach, it can happen here. A venous, aortic venous circum can be a bit more difficult. In that case, we decided to use a percutaneous approach. It can be done in the groin under ultrasound with a Shiba needle, and you can inject, as you can see, and you see the glue going up a little bit. You have to be cautious, but you see that it's quite safe, and you can ask the patient for Valsalva and have a very nice embolization. Here, a second case of unique retroaortic left renal vein. You can see it can be a bit challenging by endovascular approach, and we puncture directly under ultrasound, just above the groin, if you see it properly, and it can be done, and you see the glue injection here, directly in the Shiba, and as I told you, to me, the most tricky part is to embolize the distal part, so it's perfect in that case, and you just have to be cautious when the glue is going up, but it's not a big deal anyway. It can be very interesting for recurrence after surgery as well, because in most of cases, we talk about, the funny thing with recurrence after surgery is that we talk about recurrence, but in most of cases, this is not recurrence. Because when you do the phlebography, you see the initial spermatic vein, which is just in place, and you don't know what the surgeon did, but the ligation was not on the main spermatic vein. So I think in most of cases we talk about recurrence, but this is mainly a surgical technical failure than a recurrence. But anyway, the same thing here. This is after coiling, and you see, as I told you, that the dogma is to put the coils quite high, like a surgical ligation, and you see the kind of recurrence you can get here with a very small internal branch, giving again some pain to the patient on the left side. Impossible to go inside to put some coils, and liquids here are very interesting. You see that we got some extravasation, not a big deal. From a proximal location, in that case, with the microcatheter, you can use a higher dilution in that case, 1 to 2, 1 to 3, and you ask the patient from scratch for Valsalva to get a deep penetration, and you can see the internal small branch that you can fill in from a very proximal location. And this is the beauty of liquids, just by playing with Valsalva to the distal part and filling completely this branch. And this is the final result with some collaterals that we embolized, but in a very safe way that we checked before. Few more slides, just in general, but the same with glue. Honestly, the risk of complications after varicocele embolization is almost nil, at least major complications. You can have some spasms, some extravasation, which is easy to manage. Phlebitis of the pompiniform plexus, because some people think that even if you have some drops of glue going down to the pompiniform plexus, honestly, it's not a big deal. Nothing will happen. Don't be afraid of this. The goal is not to embolize and to occlude completely the pompiniform plexus. But if you have some drops by non-target embolization, nothing will happen. I can tell you that if you use sclerosing agents, the pompiniform plexus is full of sclerosing agents, but you don't see it, so you feel safe. No risk of hydrocele, no risk of testicular ischemia. And the follow-up, we usually discharge the patient 30 minutes later. I like doing myself ultrasound at 2 months because the only sign of efficiency is the absence of reflux into the pompiniform plexus under Valsalva. But in most of cases, the varicocele is still there, less dilated, with no hyperpressure, but with no reflux under Valsalva. And this is the only sign. And spermogram in case of semen parameter alteration. So in conclusion, varicocele is an easy disease to treat, benign disease, very common. Embolization should be, at least this is the case in our institution, urologists even don't touch any varicocele. They send us all patients because, and it should be the case everywhere, and I know it's not the case, because it gives better clinical outcomes. It's very minimally invasive, and when you do embolization, you have some advantages in using glue in terms of safety, in terms of ease, in terms of speed, and potentially in terms of long-term clinical outcomes, and which is very cost-effective in the end if you take into account everything. And that's it. Thank you very much.